Hi everyone, here is Dr. Diana Girnita. I am very happy to be here today. I am the founder of Rheumatologist on Call, this channel, and I'm coming today to answer all your questions related to rheumatoid arthritis. First, I would like to start by thanking you for taking the time to be here. And I also want to thank you for the amazing support that I received in the last 2 years. I started this channel from zero and it grew to more than 66,000 subscribers. And also my videos got about 5.2 million views. This is an amazing achievement because rheumatology and talking about autoimmune diseases, it's such a narrow field, and that's what I'm talking about in this channel. I do share with you a lot of information that is all scientifically based about autoimmune diseases, about lifestyle changes that you can take to improve your life with autoimmune diseases. I discuss about diet, exercise, mindfulness. I discuss about the power of certain supplements that are useful for rheumatoid arthritis, but also other types of arthritis. And I give you the best quality information that I can find. And it's all scientifically based. It's nothing voodoo medicine. And I educate you about everything that it means to live with arthritis. A little bit about me is that I'm a physician. I have 22 years of experience in research. I have clinical background. I worked in academia. I have my own private practice that is a telemedicine company that sees patients in multiple US states. And all over the United States, we do offer help with second opinions. But I also talk in this channel about rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and many other diseases in the rheumatology field. Today, we're going to talk about rheumatoid arthritis, and I'm going to cover a lot of topics. So if you have questions, please let me know. Let me know that you hear me well. I just want to know that you guys are connected with me. Do you hear me well? Just give me a buzz here if you do hear me well. So I was saying that I will cover a lot of topics about rheumatoid arthritis, about the signs, the symptoms. We're going to discuss those. We're going to discuss aspects of how we make the diagnosis of rheumatoid arthritis. We can discuss about what can mimic rheumatoid arthritis, and we can also discuss about treatment, everything that you want to know about steroids, about disease-modifying anti-rheumatic drugs, biologics. I will answer all your questions, and if we have time, we'll cover more, or we can do a series of these topics and we can discuss them in depth. So I will start with the signs and the symptoms of rheumatoid arthritis. As you probably know, this is an autoimmune disease that affects the joints. It can start in the small joints of the hands, of the feet, but it can start also in the big joints. And what is specific for this disease is the fact that it will affect the hands in a symmetric bilateral pattern, or will affect the feet in kind of the same way, symmetric bilateral pattern. So both at the same time. Rarely could affect one hand and then it can switch to the other hand, but primarily most of the patients that present to my office will be affected bilaterally. And besides the joint pain, I want you to know that rheumatoid arthritis is a systemic disease. And what do I mean by that? It can affect multiple other organs, and it can affect multiple parts of the body, the heart, the lungs, the kidney, the skin. You know, I had patients that had vasculitis of the skin. It can affect the eyes, so you have to be careful about your eyes. And we're going to talk a little bit about that. Many patients will present with carpal tunnel syndrome, both hands. So this is important because I had patients that were seen by other physicians when they started to present bilateral carpal tunnel syndrome. And this is something that I always draw attention to you if you ever had that kind of problem. And if you are wondering if you do have rheumatoid arthritis or not, there are just a few conditions that could cause bilateral carpal tunnel syndrome, which means that you can have tingling and numbness in those three fingers, and you can have pain when you try to use your hands. You can have that, as I told you, I had numerous patients that were seen by hand surgeons before, and then some of them, they had surgeries to correct the carpal tunnel syndrome, but it didn't work because the inflammation after the surgery will come back. So this is an important thing that I want to draw attention. And the other thing is that many patients will have dryness in the eyes, dryness in the mouth, and that could be because of ongoing inflammation. So those symptoms can be related to your rheumatoid arthritis if you didn't know. A lot of my patients will complain about fatigue. So fatigue, I know it's a very, very big concern and a big problem for patients with rheumatoid arthritis, because fatigue is not only coming because of the inflammation, because of the disease, but apparently there are some studies that they show that there are certain antibodies because of the rheumatoid arthritis that actually can affect the brain. But also when you have ongoing inflammation, you can also have fatigue because you develop anemia of chronic disease, and that can cause you fatigue. Some patients with rheumatoid arthritis can also be affected at the level of their thyroid. So they can develop both rheumatoid arthritis and can also develop thyroiditis, Hashimoto thyroiditis. This is something common. And sometimes when the thyroid is affected, you can develop hypothyroidism, and that will also cause fatigue. So if you have fatigue, then definitely reach out to your rheumatologist and ask them to look for causes, because not always the cause of fatigue is rheumatoid arthritis. So somebody here says that my eyes were not well. So that's important, because if you let rheumatoid arthritis untreated for many years, your eyes can be affected and you can actually develop problems with your vision, but even more complications than that. There is a complication that we call scleromalacia, where the white part of your eyes can become thinner and thinner, and at some point you can end up with even more complications than that. So that's why I want to draw attention towards this complexity of signs and symptoms that could be related to rheumatoid arthritis. So once again, rheumatoid arthritis is not always about your joints. Now, talking about how we diagnose rheumatoid arthritis, this is also important, because rheumatoid arthritis is not diagnosed by looking at the blood work. As you probably know, all around the world, patients will complain that the doctors in our days, they look more at the chart, at the blood work, than they look at the symptoms of the patient. And this is important, because I don't do that. I usually listen to my patients to understand their symptoms, to understand where they are coming from. And based on those symptoms, I do order blood work. And probably most of you know that the most common blood tests that we use to diagnose rheumatoid arthritis are rheumatoid factor and anti-CCP antibodies, correct? Many of you probably had those positive, one versus the other one, or you can have both, but sometimes none of those are positive and you can still have rheumatoid arthritis. If you watch my channel, you're going to notice that I have a video about what we call seronegative rheumatoid arthritis. What does it mean? It means that those patients, they do have rheumatoid arthritis, but they don't have any of the blood work positive. None of the rheumatoid factor, anti-CCP antibodies are positive. So in that situation, it's very important to track your symptoms. So what I teach my patients, and I'm going to teach you to do, because it's very important how you share, how you communicate that kind of information with your doctor, is track your symptoms. So every morning, and this is important, mornings. So every morning, write down what it hurts, what joints will hurt, the hands, the wrists, the shoulders, what it hurts, what joints. And then write down if you have morning stiffness, and that's something that many patients with rheumatoid arthritis will have. If you have morning stiffness, then write down how long is that lasting. If you have it for 30 minutes versus 1 hour versus 3 hours, because that will make a huge difference on how your doctor will understand your symptoms. And if you do have morning stiffness, you also have to write down if that morning stiffness is improved by movement or not. Somebody here, Mr. Walter Scott, he says that he has seronegative rheumatoid arthritis. So that's what I'm telling you. It's important to track your symptoms, because your doctor will understand much more from those symptoms that they can understand from the blood work. Now, if you want to know, only about 60 to 70% of patients will have a positive rheumatoid factor, and about 65% of patients will have a positive anti-CCP antibody. And about 20%, once again, 20% of patients with rheumatoid arthritis, they have none of this positive. So that's why symptoms are important. And when we make the diagnosis, the symptoms will be very, very important. When did they start? How did they start? If they involve certain joints, if they involve multiple joints. So again, symptoms are important. So let me see if we have any questions here. Somebody is asking me, how about losing hair because of rheumatoid arthritis? Yes, the ongoing inflammation can cause you to lose hair. So that's a common complaint that I have in patients that are newly diagnosed with rheumatoid arthritis. But losing hair can also come from certain medications, and I'm going to talk about that later. But one of the medications that I want to mention is methotrexate. And for that, for losing hair because of methotrexate, there are some remedies. I can point those to you when we get to treatment. Let me take another question here. What happens if no medicine will help you by visible inflammation? We'll talk about that in a second. Somebody is asking me, what about a whole bald spot for losing hair without any medication? In that situation, I think you should contact a dermatologist. They can take a biopsy and they can look for the cause of your hair loss, because it might not be related to rheumatoid arthritis. Usually rheumatoid arthritis, when it's causing hair loss, could be diffuse. The whole scalp could suffer and you could lose hair there. Rheumatoid arthritis can mimic other diseases, or other diseases can mimic rheumatoid arthritis. So that's also important, because if you think you have rheumatoid arthritis, there are certain diseases that can look like rheumatoid arthritis, but they are not rheumatoid arthritis. And this is the case of many infections. And I'm going to point towards a few infections. A very common infection that will cause symptoms that look like rheumatoid arthritis is parvovirus. So if you're in contact with your kids and your kids get parvovirus, you can get the virus, and then you can develop joint pain, usually the small joints of the hands. I didn't talk about that, but we can back off a little bit. The joints that are affected in the hands are these ones. I call them the small knuckles, the big knuckles, and the wrist can be affected in rheumatoid arthritis. And parvovirus can actually cause involvement of the small joints. Besides that, hepatitis. Okay, so this is very important, because hepatitis B or hepatitis C and even HIV can cause small joints involvement or pain and swelling in the small joints. So when you go to the doctor and you talk to your doctor and they try to assess you for rheumatoid arthritis, they have to screen you for these infections. They have to figure out if you have parvovirus, hepatitis B, hepatitis C, TB, HIV. So very, very often, the doctor will order the test for infections. There are other diseases that can look like rheumatoid arthritis. One of them is called polymyalgia rheumatica, that can involve both of your shoulders or both of your hips. So that's also important, because if you are around the age of 60, you can develop bilateral shoulder pain and stiffness, and you can develop bilateral hip pain and a lot of stiffness. And that can look like rheumatoid arthritis, but we actually test you, screen you, and based on the symptoms, we can decide that you do have polymyalgia rheumatica, for example. There are other diseases like psoriatic arthritis, and here I want to draw your attention because I see so many patients misdiagnosed with psoriatic arthritis. And for sure, we're going to talk about that in a future lecture. But psoriatic arthritis can look like rheumatoid arthritis. So if you have psoriasis, pay attention to your joints, because the joint pain from the psoriasis, which is the skin disease that can affect the elbows, the skin in the scalp, can affect the ears, behind the ears, genital areas, in the buttock area. That disease, which is also a systemic disease, you look and you think might be a skin disease, but psoriasis can affect your joints. And the difference between psoriatic arthritis and rheumatoid arthritis, we can go deep into that, but the psoriatic arthritis tends to affect more the spine and also peripheral joints, but more in a non-symmetric pattern. So it's going to skip joints. It's not going to be bilateral. Usually it's one wrist or one finger or one toe. So that's the difference, the big difference between rheumatoid arthritis and psoriatic arthritis. Some patients with gout might be misdiagnosed, or gout can mimic rheumatoid arthritis. And there are other diseases, autoimmune diseases like lupus or Sjogren syndrome. This is a topic that a lot of people in my channel will follow on. They can also mimic rheumatoid arthritis. So that's why when you come to the rheumatologist and we do the first initial evaluation for your disease, we screen you for infections, we screen you for let's say for gout, we screen you for lupus, for Sjogren, because this is important. Now, something that you might not know, but sometimes rare cancers like lymphoma can look like rheumatoid arthritis. So if you have a lot of other symptoms like, for example, let's say shortness of breath, losing weight, no appetite, if you have fevers, if you have night sweats, you have to tell about all of this to your doctor, because they can look and assess you more. If you have lymph nodes that will swell up, that's also very important to communicate to your doctor. So that's about diseases that will mimic rheumatoid arthritis. We're going to go to treatment. I know that many patients will have questions about the treatment of rheumatoid arthritis. And this is a very complex topic that we're going to try to assess probably in more sessions going live. I can answer you a lot of questions about the treatment of rheumatoid arthritis. But just as a general picture of the treatment, we do start the treatment when patients come to us and they are in a lot of pain, a lot of inflammation. We usually start with anti-inflammatory medications like NSAIDs, the ones that you find over the counter. And many patients will already take NSAIDs like ibuprofen, naproxen. They use those from over the counter. They take it and they just try to address the pain before they come to see to the doctor. As you probably know, at least in the United States, to get to a rheumatologist is between 4 and 6 months. And that's very, very unacceptable in my situation. I would say if I had to stay in pain for 4 to 6 months to see a specialist, that's really unacceptable. And that's why I started my company, Rheumatologist on Call, to give that kind of opportunity to patients to be seen when they need it the most and not wait for 4 to 6 months. And if you live in a rural area, or if you live in an area without any specialists around you, you might have to travel for miles and miles to get to a specialist. And that's bad. I mean, that's something that I cannot accept in our days, where you can do so much better for improving the access of patients to a specialist like me. But coming back to the treatment, I think that the first line of treatment after you go to see to the doctor and we try some anti-inflammatory medication, NSAIDs, we can try steroids. Now steroids, I'm going to tell you this. People love me when I give them steroids because it takes the pain away right away. It takes the pain away. In a couple of days, my patients will call me and will say they feel so much better. But patients have to understand that steroids are just a Band-Aid. It's like the bridge between where you are now and the treatment that you want to be later on. So it's very important to understand that, because you cannot stay on steroids or big doses of steroids for a long period of time. Steroids are good, are great. Somebody won a Nobel Prize for inventing the steroids, but steroids can come with a baggage of side effects. So I want you to realize that we give steroids just for a limited amount of time to spare the inflammation, to drop the inflammation, but not to continue forever or for a very long period of time. We use prednisone, we use other things. Somebody here, Caroline, says, steroids are so good for me. I believe you. I wish I could take them all the time, she says. I know. Sometimes you need them, and I'm all for that. When I have a patient that will come to me in terrible amount of pain, of course I'm gonna give them some steroids. But those steroids will be the bridge, as I said. The steroids can be associated with other medications, but don't associate steroids with anti-inflammatory medication. I mean, don't take ibuprofen from over the counter and also use prednisone, because they can interact and they can increase your risk to develop, let's say, a GI bleed. So that's dangerous. Somebody else says, prednisone, I can take that. No bad reaction to skin. Yes, so we'll go forward. Somebody else is asking me about Rinvoq. I'm going to talk about that in a second. The next class of medication, or basically the first step in approaching medication, we use these drugs called DMARDs, or disease-modifying anti-rheumatic drugs. I know this sounds complicated and it's a long name. It took me a while to learn it when I was a medical student. It looks so strange to call them DMARDs. So that's something that you probably heard, or if you didn't hear, these are the class of medication. I mean, there are multiple types of medication under this class, and I'm going to mention just a few of them. One of them is methotrexate. The other one is hydroxychloroquine. Another one is called leflunomide, and the last one is called sulfasalazine. Now, let me tell you something. Every single patient that I have, when I propose them to start on methotrexate, they are scared. And it's absolutely normal. I understand that. Because if you go on the internet and you research what is methotrexate, you're going to find out that it's a cancer drug. However, this is not only used for patients with cancer. We use methotrexate for about 60 years in rheumatology. We use much, much lower doses than the doses that were used for patients with cancer. Today, for patients with cancer, we have so many other options, but we also use methotrexate. So coming back to rheumatology field, methotrexate is one of the most common drugs used in rheumatology with great success. About 60% of patients with rheumatoid arthritis, they have great response to methotrexate. If you do it right, under very close supervision to your doctor, and if you start low, let's say 3 to 4 pills once a week, and you increase the dose gradually based on your response, because you have to let your body accommodate with this medication, adjust to a new medication, then you have a great chance to respond to methotrexate. But once again, that's what I do with my patients in my practice. I start very, very low, and we coordinate very, very closely. They see me once a month, because they are in contact with me all the time. And if something is happening, I'm there to support them. I'm there to change things. I'm there to help them go towards a better feeling with rheumatoid arthritis. Methotrexate needs to be associated with a vitamin, and that vitamin is called folic acid. You probably know about folic acid, and there is a big debate how many times you should take folic acid, if you should take it in the day of methotrexate or not take it in the day of methotrexate. I have to tell you that there is no evidence to tell you that if you take it in the day that you take methotrexate is not effective. The drug becomes not effective. So I tell my patients to take folic acid every single day. One pill, 1 milligram of folic acid every single day, and then methotrexate is administered once a week. Let me take a couple of questions from here. If does anybody have questions about methotrexate? I'm going to take a question. So how about having babies and RA? I only have one baby and I want more, but haven't been able to get pregnant for 6 years now. So let's talk a little bit about that. We'll take a break from the treatment and let's talk about that. To answer the question, yes, you can have babies while you are taking so once again, so you can have babies if you have rheumatoid arthritis. Actually, I had many patients that had babies and they have rheumatoid arthritis, but there is a but. You have to consider the time, because if you have a very active disease and the disease is not well controlled, I don't think it's good to have a baby, because you're going to be in a lot of pain and you're going to take care of you and the baby at the same time. What is interesting in certain patients with autoimmune diseases, including rheumatoid arthritis, that they remain pregnant, it's the fact that during pregnancy, you might feel great because your immune system gets into a tolerance phase. And that means that it's more accepting. It's accepting your baby. And your disease activity might be much, much, much lower. So you might feel great during that time of being pregnant. But another consideration that you have to make, if you are on certain medications like methotrexate and leflunomide, you have to talk to your doctor, because you cannot remain pregnant on these two medications, because they can affect your baby. They have a bad effect on your baby. So be careful. Use two methods. So once again, two methods of contraception while you're taking methotrexate or another drug called leflunomide. So I hope that answers your question about pregnancy. Another medication that is very similar to methotrexate is called leflunomide. Now, leflunomide, somebody else is asking me, how long should they wait until they get pregnant if they are on medication? So if you are on methotrexate or leflunomide, you should communicate with your doctor that you want to remain pregnant. And second, you should stop the medication with at least 3 months, once again, 3 months before you attempt to conceive. So this is important because you want to protect that baby. And if you somehow remain pregnant while you are on methotrexate, you should contact your doctor right away and stop the medication right away. But again, contact your doctor, talk to your doctor, and then make changes based on what the doctors say regarding your medication and your pregnancy. So we can make a whole topic about that. I think that's important, especially in young females that they are considering to remain pregnant. The medication, I actually have a video that I posted a while ago about pregnancy and rheumatoid arthritis. And there I discussed the safest drugs for pregnancy. And just to tell you about that, the safest medication for the time that you are pregnant is actually hydroxychloroquine or Plaquenil. We're going to talk about that in a little bit. So that being said, let's talk a little bit about leflunomide. I'm sorry that we have to jump back and forth, but I think that me being live gives you the opportunity to ask me questions, and I can direct you through the topic, but I also can take questions and answer them. So let's talk about leflunomide. Leflunomide is, I would say, the brother, sister of methotrexate. They are very, very well related because leflunomide does basically what methotrexate does, has the same mechanism of action in your body, but instead of taking the medication like methotrexate, you take it once a week, you can take leflunomide once a day. Now, sometimes I switch between methotrexate and leflunomide because somebody will say to me, I don't like to take medication once a week because I forget. I would rather stick with something every day. So I take that in consideration. But other times, patients will not tolerate methotrexate, and I will try a lower dose or a full dose of leflunomide. So that being said, we can switch between methotrexate and leflunomide, and they do work. Both of them, they do work pretty well in my patients. So it might work in your case as well. Another medication that I just mentioned that is safe during pregnancy and during breastfeeding is Plaquenil or hydroxychloroquine. Now, as you probably heard, hydroxychloroquine was in the news about 2 years ago because it was a drug that was actually shown to be protective or shown to be, help patients with COVID. And that's why many patients will know about hydroxychloroquine. But hydroxychloroquine is a very old drug that it was used for many years to treat malaria patients. So we took that medication and we started to use it in rheumatology also many, many years ago. I think 60, 70 years ago, we started to use this medication. And if you look at how potent this is probably not so aggressive like all the others. It's actually known to modulate the immune system, doesn't drop the immune system, doesn't immunosuppress you, but rather it will modulate your immune system to be less reactive, because when you have rheumatoid arthritis, your body is in a constant fight with inflammation. So this medication will influence certain cells that we call neutrophils and will modulate your immune response. Plaquenil actually is used in many patients, not only in rheumatoid arthritis, but also it is used for patients with lupus or Sjogren's syndrome. So it's not only used for rheumatoid arthritis. We can talk more about that. And actually, if you want, you have a video in my channel where I answer the top 10 questions that all my patients will ask. So if you go through that video, you're going to find out that Plaquenil is safe, and you're going to find out a lot of information about the most common questions that people will have regarding these medications. Now we'll transition into a topic that I think many people would like to hear about, biologics. And, I'm here to take your questions, and I'm very happy to answer your questions. Somebody was asking before about JAK inhibitors like Rinvoq and Xeljanz. We'll answer that. So when we look at the biologics, so what are biologics? If you want to dig deep into this topic, again, I have another video that will talk about biologics, about the questions that you might have related to biologics. But as a general approach, biologics are some proteins. Some of them are designed to they are humanized. We call them monoclonal antibodies. What it means is that humans were so smart, and through research for many years, they were able to find out that there are certain molecules in our body, like TNF-alpha, IL-6, IL-1, interferon gamma. There are multiple molecules that will cause inflammation. And some of these molecules, the researchers, they found them in the joints. So they found them in the fluid in the joints. So what did they think? They thought about, inventing something like a molecule that will go there and will neutralize or will inhibit that kind of molecule that produces inflammation. And in this way, you are going to decrease inflammation. And that's what they did. They invented these different types of classes of medications. And we're going to talk about TNF-alpha inhibitors. So those are monoclonal antibodies that will inhibit that molecule, TNF-alpha, which is very common in the body to produce inflammation, or IL-6 inhibitors, which will inhibit the molecule called IL-6. Those are called also cytokines, but we want to keep this discussion to understand, to make everybody understand. And there are other molecules like this pathway called JAK pathway, where these molecules, the JAK inhibitors, will inhibit not only one, but multiple molecules that will produce inflammation. And we have other drugs like rituximab or CTLA-4s that will inhibit multiple components of inflammation. So coming back to the classes, the TNF inhibitors were the first on the market. They were discovered in the 1990s, and as far as I remember, in the 1995, they started to come on the market. And the first one was called infliximab, or Remicade. Many people might know it from Remicade. There are others that were invented a little bit later, like adalimumab, or you probably heard about Humira, Enbrel, Cimzia, Simponi. There are many of them. We have many options for TNF alpha inhibitors, and we use them if the methotrexate doesn't work, or leflunomide doesn't work, or in combination with methotrexate, we can associate these TNF inhibitors to help the methotrexate to work better. You can use them by themselves. So there are patients that will take just TNF inhibitors or just biologics, but there are patients that actually associate those medications. So, and actually there is some data that will show that associating methotrexate with TNF inhibitors or other biologics works better. Again, that's a debate. If you ask, the pharmaceutical companies, they will say that you don't need methotrexate. If you ask me, I can say that many times you do need methotrexate. But again, it's what other people try to sell you and what we see in clinical practice. And in my practice, I can tell you, I have an extensive population of patients with rheumatoid arthritis, and rheumatoid arthritis is my passion, and that's why you see me talking about that a lot. So somebody here is asking, which of the biologics has the fewest side effects? So that's an amazing question. I love that question. So we can talk about the side effects of biologics. And I can tell you that there are two ways of looking at this and to answer this question. Number one, if you look at the pamphlet of each of them, each biologic, you're going to notice there are many side effects. But the majority of patients will not have side effects or will have some side effects. And if you look at the clinical practice, and that's why I like to look and advise patients that these are the most common side effects, but also every single one of you is different. Every single one of you is unique. And you might have signs or symptoms or side effects that nobody else has, or you might have some side effects that are more common. The most common side effects for biologics are infections. So that's why it's very important for patients to understand that if they are on a biologic, they should be careful. They should wash their hands. They should wear a mask. They should avoid these very crowded places where you meet a lot of people. You should avoid someone that is coughing in your face. So definitely be aware that if you have an infection or if you develop an infection, call your doctor, tell him about that. That's very important. I tell all my patients, if you have an infection, sinusitis, otitis, so inflammation in the ear, inflammation in the sinuses, or a sore throat, call me, tell me, because I will be able to treat you. And obviously, you have to stop the drug during that infection. So you treat the infection, and that's what usually happens most of the time. We treat the infection, we take you off the drug during that time, and then you can go back on the infection. Obviously, if you have many infections, we can switch the drug, or we can try to understand why you have many infections. Very rarely, I would say, patients will develop infection that will put their life in danger. And usually the infections, or most commonly, I would say most commonly, infections can happen in the first 12 months of starting therapy with biologics. So that's why, once again, I'm in contact with my patients to offer that support, to be there for them. If they happen to have an infection, they have access to me right away. We sort out things and they are safe. So that's also important to know about side effects. About other classes of medications, IL-6 inhibitors like tocilizumab, Kevzara, those are other classes of medications. So if the TNF inhibitors do not work, then you can try other classes like IL-6, or you can try CTLA-4 inhibitors like Orencia or abatacept. And if they don't work, you can still have options. You can have the JAK inhibitors. And here, I had a few questions already that I have seen here in the chat. JAK inhibitors are one of the newest classes of medication. And what is exciting about JAK inhibitors is that they are pills. So the other biologics, like TNF inhibitors, IL-6, CTLA-4, rituximab, they come as injections or infusions. So infusions means that you have to go somewhere, they put an IV in, and they get you the medication directly through an IV line. And that is very inconvenient for a lot of patients. I have to tell you that in my days, I don't think we should do infusions unless there is a specific, I would say, a specific need from that patient to have an infusion. Unfortunately, if you have Medicare, you know that Medicare will not approve injections, but rather will go towards infusions. And that's not something that for many patients is convenient. And plus, you have to pay extra costs. Think about, you go to a hospital facility, you pay their hospital facilities fees, and you're going to end up paying so much more on these medications to be given to you in a hospital setting or an infusion setting. So now, the JAK inhibitors are the pills. So many patients will be very excited because taking a pill once a day, it's such a convenient way to treat the rheumatoid arthritis. But like any medication, JAK inhibitors can cause also side effects. And because somebody actually asked me here about what is the effect of JAK inhibitors towards the heart, let's talk about that. So about 2 years ago, there was a warning that came in one of the articles that one of the medications called Xeljanz, this is one of the JAK inhibitors. So we have Xeljanz, we have baricitinib, and we have upadacitinib. I'm sorry, I cannot pronounce it right, but we have Olumiant, Xeljanz, and Rinvoq. So somebody here asked me about Rinvoq. That warning was after a few studies that were done with Xeljanz. And in those studies, it was reported that the medication increased the risk of thrombosis. What does thrombosis mean? It means that you can develop a clot that will stop the flow to your heart, to your lungs. So you can develop pulmonary emboli, you can develop myocardial infarction or a heart attack, or you can develop clots in the legs. However, that study actually told us that the dose that they used and the population where they saw this kind of side effects were people with Crohn's disease, where the dose for Xeljanz was actually double compared to the dose that we use commonly in rheumatoid arthritis patients. So in rheumatoid arthritis patients, we use 5 milligrams, 10 milligrams of Xeljanz, or 11 milligrams of Xeljanz. That's the extended release. But in Crohn's patients, the dose was 20 milligrams. Of course, you have to know about the side effect. Of course, you have to be careful. And if you have a cardiac history, if you have a history of thrombosis, like a history of lung clots, you have to tell your doctor. If you have a history of blood clots in the legs, or if you have a history of heart disease, you should tell your doctor, because at that point, the doctor might decide that Xeljanz or Rinvoq might not be the drug for you. Now, I can tell you in my experience, I have not seen that, but it doesn't mean that it doesn't exist. I'm not negating that, but I'm telling you, there are certain situations where we consider certain drugs and certain situations where we don't take in consideration these drugs for patients. And that's why I insist. Every patient is unique. Every patient will react differently to medication. And that's why you need that kind of collaboration with your doctor, where they understand where you come from, what are your fears, how you're going to approach this, and they understand what are your risk factors, and they can choose to take the medication that is appropriate for you. Any other questions about JAK inhibitors? If you do have it, you can drop it here in the chat. I'm very happy to answer them. There is another medication called rituximab, but I would like to tell you that rituximab is kind of the last resort. That's a very, very strong medication that we use in many other diseases, very complicated diseases like, for example, vasculitis. Rituximab is also used in patients with lymphoma. So if we have to go that route, basically you have to exhaust many of the other options, and I would not go to rituximab if I didn't try many of the other drugs, because it might be too much for patients. Another question that I have about JAK inhibitors: how long can you take JAK inhibitors for? So the question is, how long can you take JAK inhibitors safely? So basically, you can take them for a long time. We don't really know, and that's another discussion, another debate in rheumatology. We don't know how long we should treat our patients. We think indefinitely, but we also have to acknowledge that some patients, they have periods in their life when they get into remission. So again, I'm insisting on that collaboration with the doctor, because if you don't need so much of that medication, with the agreement of your doctor, with the understanding that it can happen for you to have a flare-up if you stop the medication, I usually don't recommend to stop medication right away. Never, ever I recommended that. But I would work with my patients to decrease the dose of medication and go down very slowly but safely, and use the minimum amount of medication, because using less medication, you will be protected from the numerous side effects. So that's why it's important to have that collaboration. And if you feel great, fine, but you have to feel good for a period of time before you make those kind of adjustments. And if you do the adjustments, then you have to have the doctor on board. You don't do it by your own. So please don't do that. So somebody says, if you are on Coumadin, will stop the clots if you are on JAK inhibitors? I'm sorry, I don't know to answer this question right away. I will look into that. Basically, Coumadin will prevent you from developing blood clots, but I don't think there was any study that I'm aware of. If it's out there, I don't know. And I will look for it. But I don't think there is a study done on people that were taking Coumadin and were also. So Coumadin, for those of you that do not know, it's a medication that will make your blood thinner, and it's usually given to people that have a history of blood clots, or, there are other considerations. But again, I don't know if there was a study on patients that were taking Coumadin and they were also taking JAK inhibitors. I don't think, but again, I might be wrong. Now, a lot of you, another question here: is rheumatoid arthritis related to diffuse systemic sclerosis? So it could be, but could be that your diffuse systemic sclerosis can cause symptoms that they look like rheumatoid arthritis. So if you look into my channel, I have a video about systemic sclerosis, because that's a disease that is very hard to diagnose, especially in the beginning. This is a disease that could affect very young females, and it can start with joint pain in the hands, with swelling of your hands, but it can also give you a lot of itching, swelling. The swelling is diffuse, it can give you itching, and patients will wake up with a lot of stiffness. They cannot close their fist in the morning. So it can look like rheumatoid arthritis, but could not be that. If they are associated, it could be rarely. We call this overlap syndromes, where we see features from rheumatoid arthritis, like clinical features from rheumatoid arthritis, but also we see clinical features from systemic sclerosis. So it could be that situation of an overlap syndrome. Somebody else is asking me here, I have rheumatoid arthritis for almost 30 years, and I would like to stop methotrexate now. I'm 71. So Ms. Wing, I think that you should discuss with your doctor if you are ready to decrease and stop methotrexate. I would not advise you to stop methotrexate, cold turkey, because you could end up with a lot of complications in terms of you could have a lot of pain. It could actually throw you into a bad flare-up. So with your doctor, you should coordinate to decrease slowly the dose, and then try to stay without it, or replace methotrexate with something milder, something like hydroxychloroquine. Again, you have to talk to your doctor. Somebody else is asking me, adalimumab can we use adalimumab for psoriatic arthritis? Absolutely, yes, we can. And I have, again, many patients with psoriatic arthritis, and I use adalimumab to treat them. It does work very well. Now, a big question that I get from my patients, which one of the biologics is best? And the answer is, we do not know. We are not sure, because the studies that were done so far, they compare the drugs in the term of, is this inferior to the one that we have on the market, or it is not? So if you fail a medication like TNF inhibitors, they would select that population of people that fail TNF inhibitors, and they will try a new medication, and they will say, okay, if you fail this, you can try this new one in terms of new class of medication. Or they will do studies that will say, this medication is as good as the other medication. Like this medication, like Rinvoq, is as good as methotrexate, not methotrexate, is as good as another TNF inhibitor. So that being said, it's important for you to understand that, we don't know which one is best. Now, when to start a biologic medication? As I told you, we usually start biologic medication after we go through methotrexate or other DMARDs, and then we start biologic medication, unless you have a contraindication or you don't tolerate them as well, or you don't tolerate them. Another question, just give me a second. Just give me a second. Another situation is when is better to have injections, or is it better to have injections versus pills? And the reality is that, as I told you, pills are probably more convenient. Injections are not better than pills. And just a second. So as I told you, injections are not better than pills. So can you please discuss Rinvoq? Just give me 1 second, because I have someone that is calling at the same time. So I already discussed about Rinvoq. So Rinvoq or tofacitinib can be also used for other indications like psoriatic arthritis, and it is effective in that situation as well. Okay. And how about I will answer you another question about biologics and the risk of cancers or the risk of heart failure. Once again, you have many information in my channel, but to answer you that question, the evidence is still low. There are situations where certain medications like TNF inhibitors can increase a little bit the risk of skin cancer, and that's why I recommend to my patients to have a skin exam every single year, and also to report me if they have new symptoms like the ones that I mentioned, like night sweats, or losing weight, or losing their appetite, or lymph nodes. I do recommend that to them to contact me and discuss that. So that being said, I just want to thank you for being here. I'm so excited to see so many people that are listening to my talks. And once again, thank you so much for supporting my channel. Subscribe to my channel, support the mission, share my videos with other people that will benefit from this information. I know many people, they try to go on internet and get their information, but you better get it from an expert than get it from someone that doesn't treat rheumatoid arthritis. I treat rheumatoid arthritis every day. I have experience for many years. Take that information that you find out there. Don't believe everyone that will try to sell you things, because whatever they sell you, it's not usually helpful. And we're going to talk about that, the remedies or supplements. We can talk about many of these things. We can talk about the anti-inflammatory diet. We will have a specific topic or a specific lecture with anti-inflammatory diet, and we can talk about many other lifestyle changes that are so important for patients with rheumatoid arthritis. As you probably know, I'm a huge advocate of implementing the right diet, the right lifestyle changes, like the certain types of exercises, mindfulness, and many other options that are proven scientifically to work. And once again, thank you very much. It was a pleasure to be with all of you today, and I'll see you back soon. Have a wonderful day, everyone. Bye-bye.